The United States spends more on healthcare than any other country. Yet, when it comes to maternal health, especially for pregnant people with substance use disorder, it falls painfully short. Meet Savannah. Savannah is 27 years old and pregnant. She thinks she is in her second trimester. This is her first time trying recovery. Her day begins before sunrise. She doesn't have a phone to check the bus schedule, so she relies on times posted at the corner stop. If the 5:42 bus is pulling away, she knows she's already late. Savannah has been staying on a friend's couch. Again, the shelter had a spot, but just for her. Her partner, Rob, wasn't allowed because couples aren't permitted. Rob is also in recovery. He's on probation after a drug possession charge. Because of his record, Rob isn't allowed to stay overnight if Savannah is hospitalized, even for pregnancy complications. If their baby needs a higher level of neonatal care, like transfer to a regional neonatal intensive care unit far from home, Rob might not be allowed to stay and support Savannah or their newborn due to hospital policies around visitors with prior offenses. These rules exist to protect other patients and hospital staff. For Savannah, it means that she will face some of life's toughest moments alone. This baby is Savannah's third. Her mom has custody of her two older children. If Savannah wants a chance to reunify, she has to prove consistent engagement with prenatal care, recovery services, child welfare, mental health counseling, and more. But every program has its own portal, its own forms, its own intake staff, and without a phone, it's next to impossible to keep up. Today, she has 2 appointments, a prenatal ultrasound and a counseling visit. They're across town from each other. Savannah doesn't have a car. Medicaid transportation requires 72 hours notice and a phone to confirm. At the Women's Health Clinic, she's told she needs labs drawn and that it takes an hour to complete. Savannah doesn't understand why. Last time, her obstetrics appointment felt rushed and the front desk staff seemed frustrated when she asked questions. She quietly walks out before the blood draw is complete. When she finally confides in a provider about her recovery, the visit ends with a warning. She will face child welfare involvement. So next time, she says nothing. At the treatment center, she's 15 minutes late. Her slot is marked a no-show. When she returns to the shelter, her bag is gone. She missed curfew. The bed was given to someone else. She ends her day curled up next to Rob in an abandoned building. It's not safe, but at least they're together. Savannah is not failing the system. The system is failing her. Savannah is trying to be responsible. She's navigating complex medical and social needs in a system never designed to meet her where she is. She's doing what she can with what she has. She's showing up, she's trying, she's in recovery. With the right support, Savannah's story could end differently. Recovery is possible. According to the Substance Abuse and Mental Health Services Administration, 75% of people with substance use disorder recover when they have access to care, community, and compassion. What if Savannah didn't have to choose between recovery and prenatal care? What if OB care, recovery support, therapy, and food access all lived under one roof? Why don't we make it a little easier to get there? Why don't we build care around people like Savannah, not the other way around? Imagine a single clinic where she can see her OB provider, her addiction specialist, a peer recovery coach, and her therapist on the same day in the same place, where her labs are drawn on site, where she isn't penalized for needing help, where her care doesn't end at the clinic door, but reaches into the community, helping her navigate housing, courts, family reunification, and the systems that shape her daily life, where peer coaches, navigators, and community partners walk beside her, not just in recovery, but in rebuilding her life. Caring for pregnant patients with unique needs isn't new. For example, there are tumor clinics for those with cancer and cardio-obstetric clinics for those with severe heart disease in pregnancy. Now is the opportunity to bring specialty care to the region for pregnant patients with substance use disorder. That's the promise of the University Health Ember program, empowering motherhood through behavioral health, education, and recovery. That's what we will deliver. When we talk about recovery, let's talk about more than sobriety. Let's talk about safety, housing, dignity. Let's give recovery for pregnant people a place to thrive in Kansas City, Missouri.